Hello students, welcome to chapter related to concepts of care for patients having problems, conditions related to the spinal cord. Actually, we're going to review the spinal cord injury, and I want to start with this video, and I am gonna ask you, this video is excellent. So please make sure you have the video available in your cell phone. I don't know. Make sure you have the video available for you to review. This is an excellent, fabulous, spectacular video, okay, that I found for you. Okay, so let me play the video for you. Spinal cord injury.
The spinal cord, enclosed in the spinal column, functions as a communication gateway between the brain and the trunk and limbs. It does so by way of spinal nerves, which send sensory information from all over the body to the brain and convey central instructions from the brain to body muscles and organs. There are 31 pairs of spinal nerves. Each arise from a segment of the cord and innervate a particular part of the body. They are named after the vertebra from which they emerge. Accordingly, there are 8 pairs of cervical nerves from C1 to C8, 12 pairs of thoracic nerves, T1 to T12, 5 pairs of lumbar nerves, L1 to L5, 5 pairs of sacral nerves, S1 to S5, and 1 pair of coccygeal nerves.
I'm going to stop the video right there. So altogether are 31 nerves, okay? When we analyze the dermatomes, which are part of the skin related to these nerves, it's only 30 because C1 is not included. We are going to review this further, but I want to start presenting this so you don't get confused with the dermatomes, okay? Let's continue.
Spinal cord injury is most commonly caused by trauma to the spinal cord, but there are also non-traumatic causes.
You see, the non-traumatic could be osteoporosis, arthritis of the spine, spinal cord inflammation, multiple sclerosis, cancer. Maybe could be a spinal stenosis, which is the narrowing of the spinal and is a non-traumatic cause as well, okay?
As injury occurs, spinal nerves are damaged, and the communication between the brain and the body is blocked. Because spinal nerves are responsible for both sensory and motor functions, spinal cord injury may cause loss of both sensation and muscle control. The latter not only leads to paralysis, but also dysfunction in processes such as urine voiding, bowel movement, breathing, and speaking. The higher the injury occurs on the cord, the more nerves are affected, the more extensive the disability.
The higher the nerves are damaged on the cord, the higher the damage, more nerves are damaged. Meaning, cervical injuries are causing more damage than thoracic, lumbar, and sacral. Okay?
At the lowest levels, injury may result in some loss of function in the hips and legs, little or no control of bowel or bladder, and impaired sexual functions, but the patient may still be able to walk. At lumbar levels, the chance of walking recovery is greatly reduced. Patients will typically require manual wheelchair or walking braces. Thoracic injury additionally affects abdominal, chest, and back muscles. Patients with low cervical injury may also suffer on top of all that from loss of control of arms and hands at various degrees. High cervical injury usually results in total paralysis from the neck down. In addition, patients may not be able to breathe on their own. Their ability to speak is also reduced.
Okay, so this is an easy way to remember how the movement is going to be affected. This doctor is explaining the damage from the bottom going up. So the sacral is close to the bowel and bladder and the hips, okay? Now, lumbar is going to have all of the same problems below, plus very low chance of walking. If we go up, the thoracic is gonna have all the problems below, plus control of abdominal, chest, back muscles. So the thoracic is in this area where the abdominal, chest, and back muscles. So it's easy to remember because it's the area around T1 to T12. Then the low cervical is C5 to C8 is damage all of below, but also damage and lack of control in arms and hand is C5 to C8 is related. You see the drawing here. And then the high cervical is a total paralysis from neck down because includes the spinal nerves in the brain close to the brainstem and the cerebellum, which is the center of the movement, okay? And also the inability to breathe on their own and inability to speak, okay? This is an excellent video and it's easy to understand.
There are two broad types of spinal cord injury, each consisting of several levels. Tetraplegia, formerly termed quadriplegia, is loss of sensory and or motor functions from the neck down, including paralysis of both arms and legs. And paraplegia is when there is disability in the trunk and both legs, but not the arms. Spinal cord injuries are also classified by degrees of severity. Complete injury is when all sensory and motor functions below the injured level are lost, and incomplete injury is when some functions below the injured level remain. There are several grades of incomplete injury which can be assessed using the impairment scale by the American Spinal Injury Association. Damage to the spinal cord cannot be reversed, but emergency and early treatments can help prevent further damage and minimize the severity. People with mild injuries at lower levels may partially recover with rehabilitation. Modern equipment and devices can help patients manage daily activities and return to a productive life.
Thank you so much. In less than 4 minutes, we got the whole picture of the conditions and the levels of injuries of the spinal cord. So we know incomplete is going to be considered. First, we check what is the injury located, and then we are going to see if the damage involves sensory and mobility from the injury below. That is considered a type of spinal cord injury complete. If we locate the level of the injury and we check the sensory and motor below that level and there are some responses, means that the injury is incomplete. Okay, so now mechanisms of injury. Sources of force include direct injury to the vertebral column, fracture, dislocation, and subluxation, which is a partial dislocation on penetrating injury from violence. And this is talking about gunshot or knife wounds. Although in some cases the cord itself may remain intact, and other items it undergoes a destructive process caused by contusion, which is bruise, compression, laceration, or transaction, severing of the cord, either complete or incomplete. The causes of SCI, spinal cord injury, from now on I'm gonna name it SCI, can be divided into primary and secondary mechanisms. 5 primary mechanisms that result in a SCI are hyperflexion. This is a sudden and forceful acceleration, movement of the head forward, hyperflexion, the head forward, causing extreme flexion of the neck. And this is often a result of a head-on motor vehicle collision or diving accident. Let's go to figure 37.2. Here you have the hyperflexion. Okay, we have to monitor our children that are, for example, in the in bicycles or scooters, and they are, for example, they hit the trees or any object or or wall in front of them, because this hyperflexion could happen, and probably at the moment they will not feel the impact, but later, even after decades, this hyperreflection can cause problems. This is often, we know that flexion injury to the lower thoracic and lumbar spine may occur when the trunk is suddenly flexed on itself, such as occur in a fall on the buttocks. Okay. Hyperextension occurs most often in vehicle collisions in which the vehicle is struck from behind or during falls when the patient's shin is struck. This type of vehicle accidents are very common, and you nurses, the ones who want to work in ER or ICU, are gonna see many cases of this, many. The head is suddenly accelerated and then decelerated. You need to master this. Let's see this one, hyperextension injury of the cervical vertebrae. You see, so the area that is compromised is the cervical, C1, C2, C3, C4, C5, I don't know. Okay, depends on whatever the images, the MRI, CT, or X-ray is going to mention in the report. Axial loading or vertical compression injuries resulting from diving accidents, falls on the buttocks, or a jump in which a person lands on the feet can cause many of the injuries attributable to axial loading. 37.4. A blow to the top of the head can cause the vertebrae to shatter. Pieces of bone enter the spinal canal and damage the core. 37.4. We are going to see this one. Okay, so I'm gonna ask all of you who have children and you are registering your child in swimming pools, in swimming classes, try to be present in these classes, okay? Because the injury that we can see on the right is very common. We don't know how deep is the swimming pool. And again, probably the child is not going to be affected at the moment, but this type of injury is going to cause problems later as they grow. Okay, let's go back to the topic, and then excessive rotation. That's another type of spinal cord injury, which results from injuries that are caused by turning the head beyond the normal range. Who's doing that? Penetrating trauma is classified by the speed of the object. It could be a bullet, a knife, and low speed or low impact injuries cause damage directly at the site or local damage to the spinal cord or spinal nerve. In contrast, high-speed injuries can occur from gunshot wounds, cause both direct and indirect damage. Secondary injury worsens the primary injury and may result in death. So we are moving. Secondary injuries could be hemorrhage, ischemia, lack of oxygen, typically from reduced absent blood flow. And I am very worried about ischemia, because with that ischemia, we are going to have damage and in the process of tissue perfusion. Okay, and it's all about the healing is coming from the amount of blood with all those nutrients and the perfusion, which is the oxygen. So hypovolemia, decreased circulating blood volume, you see. So if we don't have enough blood and we don't have oxygen, how the tissue is going to heal. Impaired tissue, impaired tissue perfusion from neurogenic shock, which we are going to analyze in a few minutes, and local edema. So Professor Matalana, what is neurogenic shock? It's a type of shock that can occur in clients who have severe spinal cord injury. Dilation of blood vessels leads to decreased perfusion to vital body organs. So the vessels are going to dilate. And of course, because the veins and the arteries, the circulatory system is elastic. If dilation occurs, the volume of the blood is going to be the same, but is not going to occupy the area of the vessel. I hope you can visualize that and you can understand that. In neurogenic shock, loss of blood vessels, tone dilation after severe core injury may result in hypoperfusion, of course, because since the blood is not occupying the full area of the vessel that is expanded. Remember I told you the vessels are they have two characteristics. They are permeable, so they have these little holes, and they are elastic. So if the vessel is expanding, the blood is not going to get to these little holes, and it's not going to transfer the nutrients through those holes. I hope you can visualize that. Patients who have SCI have a decreased life expectancy owing to complications of mobility, or more often some types of infection. The major causes of death are pneumonia and septicemia. Of course, because if you don't have the good blood and the good oxygen, and if the patient is having any infection, the system does not provide the good immunity because the blood is not there. And of course, septicemia is going to occur, which is a infection of the blood, right? Generalized septicemia. Okay, etiology and genetic risk. Trauma is the leading cause of spinal cord injuries, with more than a third resulting from vehicle crashes. Yes, especially nowadays, scooters are, these type of accidents are everywhere. Other leading causes are falls, acts of violence, gunshots, and sports or recreation-related accidents. SCI from falls are particularly likely among older adults. Spinal cord damage in older adults can also result from non-traumatic vertebral fracture and diseases such as tumors or degenerative conditions. Incidence and prevalence, estimated 300,000 or more individuals live with SCI as a physical disability. That's why we have many physical therapists, clinics, and office, right? And okay, almost 80% of all SCI occur in young males, with the majority being white. Cervical cord injuries are more common than thoracic or lumbar cord injuries. The most common neurologic level of injury is C5. Patients with paraplegia, T12, and L1 are the most common levels. The average age of patients who have SCI is 43 years old. And that's good to know. Okay, so your C5 is the most common neurologic level of injury for patients with paraplegia. T12 and L1 are the most common levels. Veterans and spinal cord injury, SCI is more prevalent among veterans who served in combat in Iraq and Afghanistan when compared to those who served in previous wars. And they are injured from blunt trauma caused by blast injuries. They are having a traumatic brain injury and amputation of one or more limbs. It's very sad. Okay, this situation is very sad, really. I don't know why we need to get to that point. Health promotion, disease prevention. The prevention is by ensuring adequate protective measures, padding and helmets for sports and recreational activities, to wear seat belts at all times when driving, and to avoid impaired driving caused by alcohol, marijuana, and other substances. Instruct them on a danger of diving into shallow pools or other waters when the depth is unknown. Parents, try to go with your kids to the swimming classes. Water should be at least 9 feet deep before diving is attempted. Okay. Recognize cues assessment history. Important data include medical history, including osteoporosis or arthritis of the spine. So if they are having these conditions, of course, on top of that, if you're having a SCI um, presentation, is everything is going to get worse. Congenital deformities, cancer, and previous injury or surgery of the neck or back. History of any respiratory problems, especially if the patient has experienced a cervical SCI. Initial assessment. The initial and priority assessment focuses on your ABCs, airway, breathing, circulation. The patient with a cervical SCI is a high risk for respiratory compromise because cervical spines C3 to C5 innervate the phrenic nerve controlling the diaphragm. Okay, so airway, breathing, circulation. Evaluate pulse, blood pressure, and peripheral perfusion, such as pulse strength and capillary refill. Multiple injuries may contribute to circulatory compromise, from hemorrhage, hypovolemic shock. Assess for indications of hemorrhage. Use the Glasgow Coma Scale or other agency-approved assessment tools to assess the patient level of consciousness. Cognitive impairment as a result of an associated traumatic brain injury or substance use disorder can occur in patients with SCI. Spinal shock, also called spinal shock syndrome, occurs immediately as the corpse responds to the injury. This patient has complete but temporal loss of motor, sensory, reflex, and autonomic function that often lasts less than 48 hours. So that's a number you need to remember. A patient is presenting in ER and probably he is having a spinal shock. We have to wait for 48 hours to see if the system is going to go back to kind of normal, right? Common symptoms include decreased heart rate, increased blood pressure, and pale gray or flushed skin. Spinal shock is not the same as neurogenic shock. So in a spinal shock, again, we are going to have a temporary loss of motor, sensory, reflex, and autonomic function that often lasts less than 48 hours but may continue for several weeks. Okay, so those are the functions the patient is going to be affected in a spinal shock. Remember, less than 48 hours. This is going to behave like that. Sensory perception and mobility assessment, assessment of the patient mobility and sensory perception status to determine the level of injury and establish baseline data for future comparison. It's always good to have to perform continuous assessment. I basically I will suggest you something. I know there's a lot of theory, a lot of signs and symptoms to monitor, different types of this and that, but not everybody behaves the same. The nervous system of the persons are acting differently. So in order to look for patient safety and protect your licensed nurse, I will conduct my assessment depending on the cause between every 2 to 4 hours. When I say assessment, I will check my respiratory status, make sure you know how to do your respiratory status and your lung sounds. I will check for pulse ox, capillary refill, your cardiac assessment, temperature, pulses, okay, every 2 to 4 hours. Sometimes in the theory, we're going to come across 8 hours or every shift. Nurses, compassion, compassion, compassion. Take care of the patient every 2 to 4 hours. Protect your license. You can easily identify progression or any problem if you go and assess the patient frequently. So tetraplegia, also called quadriplegia or quadriparesis, involve all 4 extremities. Tetra is the prefix of equal, means 4, tetra, 4. 4 extremities as seen with cervical core and upper thoracic injury. So the cervical core, you know, there are 8, 1 to 8, and the thoracic injury is 1 to 12. So probably all the way to T5, T6, okay? Because it's upper thoracic injury. Paraplegia, paralysis, or parapesis involve only the lower extremities. Paraplegia, only the lower extremities, as seen in lower thoracic and lumbosacral injuries or lesions. So we're talking about your T6, T7, all the way to the lumbar, okay? L1, L2, the neurologic, and that's good to know. That's good to know. The neurologic level is determined by evaluating the zones of sensory and motor function known as dermatons. This is the area of the skin in which sensory nerves derive from a single spinal nerve root, and myotomes is the set of muscle innervated by a spinal nerve. The patient may report a complete sensory loss, hypoesthesia, decreased sensory perception, or hyperesthesia, increased sensory perception. So, Dr. Matalana, what is the difference between a dermaton and myotome? So, these are 2 areas of the body that are served by the spinal nerves, right? The cervical, C1 to C8, thoracic, T1 to T12. You have your lumbar, L1 to L5, your sacral, L1, S1 to S5, and the coccyx, the one related to the coccyx, which is only 1. So dermatome is a distinct area of skin, is the skin innervated by a particular spinal root, whereas myotome is a group of muscles, not the skin, innervated by a particular spinal root. There you go, you have the difference, right? I want to show you a small video, a short video about the dermatomes. It's very short, and let's see. So you can identify and understand this much better. Okay, there is no music here, so you're going to see, for example, if you see you have your cervical here, but the dermatomes, they don't have C1. So you're going to see C8, C7, 6, 5, 4, 3, and 2. So this is the area. So if the damage was in C2 around the neck, the skin related to the damage is going to be the top of the head. C5, for example, okay, the top of the head, C2. C5, you see this purple goes all the way on top of the, next to the neck, the clavicle area. And okay, here you go all the way to S5. This is the skin that is going to project where the injury was in the spinal nerve. Now, let me, C7, for example, goes behind the elbow and is compromising the first 2 fingers of the hand, the index and the middle finger. For example, if the injury was in C7, the extent of the skin in relation to that injury is going to be all the way of the 2 fingers of the hand. And you're going to see this is C6, the one with the lines. C5, you can see here, goes below the clavicle, kind of touches half of the shoulder and goes in the inside part of the arm, and basically goes on top, I would say, the brachial pulse, right? That area all the way to the wrist. You see, it's different. T1 also, you see, is basically in the upper part of the breast, and T12 goes all the way to the pubic area. Okay, so these are the dermatomes. Okay, so it's easy. In acute SA spinal cord injury, monitor for decreasing sensory perception from baseline, especially in a proximal upward dermatome, which is the ones that are covering the cervical area, the C2 to C8. Remember, in dermatomes, we don't have C1. And new loss of motor function and mobility. The primary healthcare provider may also test deep tendon reflexes, including the biceps C5. Oh, you see C5, the triceps C7, patella L3, and ankle S1. So the C5 is covering the brachial. It's not unusual for these reflexes, as well as all mobility and sensory perception, to be absent immediately after the injury because of spinal shock. And after a spinal shock has resolved, the reflexes may return. And what is the time that we need to look for? 48 hours approximately. Remember that this is theory, not everybody behaves the same. Cardiovascular and respiratory assessment. Dysfunction may result in reduction of the sympathetic fibers of the autonomic nervous system, especially in the injury, if the injury is above the 6 thoracic vertebra, so T6, right? As I mentioned before, bradycardia, hypotension, and hypothermia occur because of loss of sympathetic input. Systolic blood pressure below 90 requires treatment because lack of perfusion to the spinal cord could worsen the patient's condition. And that is all good to know. NCLEX material. They are going to bombard you. A patient presents to the ER with an injury in T5, and what is the nurse supposed to, what are the findings for the nurse based on this injury? Option A, bradycardia and fever. Option B, I don't know, maybe sweating, lack of vision, and so on. So you need to master this. A patient with cervical spinal cord injury is a risk for breathing problems. The cervical is always respiration, okay, breathing, the compromising area of the lungs and breathing is an issue, resulting from an interruption of spinal innervation to the respiratory muscles. Complete respiratory assessment, including pulse oximetry, arterial, to double check for arterial oxygen saturation at least every 8 to 12 hours. That's too much. I think that's too much. Anyway, that's the theory, that's the protocol. In my opinion, if I were you, I will conduct my assessment more often in the acute stage. It doesn't matter. We are not, I think we shouldn't be waiting for the patient to be acute to conduct assessment. And oxygen saturation, especially if we are talking about the respiratory, function. An oxygen saturation of 92 or less and adventitious breath sounds may indicate a complication such as atelectasis or pneumonia. If we can prevent this with more often assessment, 92% saturation is not good. Autonomic dysreflexia, sometimes referred to as autonomic hyperreflexia, is a potentially life-threatening condition in which nauseous, visceral, or cutaneous stimuli cause a sudden, massive, and uninhibited reflex sympathetic discharge in people with high-level spinal cord injury. And this is good to know. Maximum NCLEX alert autonomic dysreflexia. This is a question in all the books that I've reviewed. All the books, autonomic dysreflexia, spinal shock, neurogenic shock, you need to master those. So key features of autonomic dysreflexia, because these are life-threatening conditions, and NCLEX is all about safety. So sudden significant rise in systolic and diastolic blood pressure with bradycardia. Okay, profuse sweating, for example, rarely occurs below the level of the lesion because of sympathetic cholinergic activity. Ghost bump, flashing of the face, blurred vision, spots in the patient's visual field, nasal congestion, onset of severe, and the list goes on. Try to memorize. I usually don't suggest my students to memorize stuff, and always I tell you to know the story, to know your map, the pathophysiology, but in this case, autonomic dysreflexia, try to memorize this. The causes of this are typically GI, gynecologic, and vascular stimulation. Specific risk are bladder distension, urinary tract infection, epididymitis or scrotal compressions, bowel distension or impaction from constipation or irritation of hemorrhoids, pain, circumferential constriction of the thorax, abdomen, or an extremity, contact with hard or sharp objects, and temperature fluctuation can also cause AD. Patients with altered sensory perception are a high risk for this complication. Gastrointestinal and genitourinary urinary assessment in order to prevent autonomic dysreflexia. Assess the patient for internal bleeding, such as abdominal distension, pain, paralytic ileus. Hemorrhage may result from the trauma or may occur later from stress, ulcer, or the administration of steroids. Okay, be careful with the steroids because they are to hide the symptoms of the body distress, right? Abdominal pain, paralytic ileus may develop within 72 hours of hospital admission. After the first few days, the spinal reflexes that innervate the bowel and bladder usually begin to establish function. So 48 hours, a little bit more, you want to check on this. Assessment of patient for long-term complications. Patient with complete spinal cord injury are at risk for complications that result from prolonged impaired mobility, of course, including pressure injuries and venous thromboembolism. And these are hospital-acquired conditions. Nurses need to monitor this in order to prevent these complications. The hospital is not being reimbursed if this happened in the hospital, which is a secondary factor. The most important is patient safety first and your license. Monitor this. Skin integrity, signs of VTE with vital signs, including lower extremity, deep vein thrombosis. This is a no-no, hospital-acquired conditions. Bones can become osteopenic or osteoporotic without weight-bearing exercises. Yes, because the patient is having mobility issues. Placing the long-term SCI and risk for fractures. Another complication of prolonged immobility is the heterotopic ossification, bony overgrowth, often into muscle. This is very painful, extremely painful. Assess for swelling, redness, hyperpigmentation, warm and decreased range of motion of the involved extremity. So besides your regular vital signs, again, I'm going to repeat, check for fever, your temperature, right? Your respiratory assessment, your cardiovascular assessment. You have to check the pulses. You have to check for capillary refill, your saturation, also check for these skin changes, okay, and provide range of motion to these patients, okay. Psychosocial assessment, of course, these patients are going to be with a lot of emotional reaction, different emotional reactions, right? All the way from sadness, depression to aggressiveness sometimes. Aggressive rehabilitation can help most patients live a productive and independent life. Laboratory, of course, they are going to do a spine CT, MRI, series of x-rays of the spine to identify vertebral fracture, subluxation, or dislocation. And usually the order is first the x-rays, and then based on findings they are going to do the CT or the MRI or both, okay. So the four things that we need to monitor that are important for nursing care are potential for respiratory distress, potential for cardiovascular instability, potential for secondary spinal cord injury due to hypoperfusion, and decreased mobility and sensory perception. Let's go number one. Factor number one, managing the airway and improving breathing. Intervention, airway management is the priority for a patient with cervical spine cord injury. So far we have repeated this several times. So cervical is related to the breathing, you're right, the respiration. Patients with injuries at or above T6 are especially at risk for respiratory distress and pulmonary embolus during the first 5 days after injury. So your patients with cervical all the way to the upper thoracic that involves above T6 are in risk for this. Developing on the level of injury, depending on the level of injury, intubation or tracheotomy with mechanical ventilation may be needed. Assess breath sounds every 2 to 4 hours during the first few days after SCI, and document or report any adventitious or diminished sounds. That's what I'm telling you. You need to master your respiration assessment, your lung sounds. Monitor vital signs with pulse oximetry. Watch for changes in respiratory pattern or airway obstruction, respiratory rate. Intervene per agency or primary healthcare provider protocol when there is a decrease in oxygen saturation to below 95%. Here in the picture you can see the cough assist technique for patients with high spinal cord injury. I have seen many nurses that are not comfortable performing this because the cough is gonna come on my face. So wear your mask, wear your goggles, and do your job. Nursing is all about compassion. You need to perform what is needed in order to save people's life. You have to be prepared for this. There's a lot of equipment that you can use, okay? And nurses, do your job. Please don't try to skip these practices just because you don't feel comfortable that the patient is going to cough on your face. It could happen to you in any moment. Okay, one day you are in your bicycle and God forbid what's going to happen. Do your job, nurses, please, with compassion. Respiratory secretions are managed with manual assisted coughing, pulmonary hygiene, and suctioning. Implement strategies to prevent ventilator-associated pneumonia, which is another hospital-acquired infection. Is a no-no. No. When the patient needs continuous mechanical ventilation as needed, encourage the non-mechanical ventilated patient to use an incentive spirometer. And I'm sure in your open lab you are practicing that. You need to master that. The nurse and respiratory therapist perform a respiratory assessment at least every day, 8 hours, which is too long in my opinion. Okay, the book is saying this, you go whatever the theory is saying. I will monitor every 4. in this case. In some cases, it may be necessary to perform oral or nasal suctioning if the patient cannot effectively clear the airway of secretions. Again, each body is different. We don't know if the body is having any problem with the immune system and is causing a lot of secretion. So if you're going to monitor every 8 hours, probably you're going to find a lot of secretion. Monitor frequently, please. Teach the patient who is tetraplegic to coordinate cough effort with an assistant. Have the patient take a breath and cough during expiration. The assistant locks the elbows and pushes inward and upward as the patient coughs. This technique is sometimes called assisted coughing, quad cough, or cough assist. Repeat the coordinated effort with rest periods as needed until the airway is clear. Wear your gown, wear your goggles, wear your mask. I mean, there's a lot of protective equipment you can use for this purpose. Monitoring for cardiovascular instability. The patient is expected not to develop neurogenic or hypovolemic shock due to hemorrhage and is expected to be free from episodes of autonomic dysreflexia, which is a life-threatening condition. This is the factor number 2. Maintain adequate hydration through IV therapy and oral fluids as appropriate, depending on the patient's overall condition. Neurogenic shock, which may occur within 24 hours after injury, most commonly in patients with injury above T6. So the patient is coming to ER, is presenting, probably we're going to have some spinal shock. We need to monitor the first 48 hours, but also in the first 24 hours, the patient is in risk for neurogenic shock. So too many important things are happening the first 48, even 72 hours, okay? Disruption in the communication pathway between upper motor neurons and lower motor neurons could occur. Dextran is a plasma expander, may be used to increase capillary blood flow within the spinal cord and prevent or to treat hypotension. Remember I told you about the lack of enough blood to cover that vessels dilation, so you have the plasma expander. Atropine sulfate is used to treat bradycardia if the pulse rate falls below 50 to 60. Hypotension, if severe, is treated with continuous IV symptomimetic agents as nephrelefrin, dopamine, or other vasoactive agents. Critical rescue, monitor the patient with acute spinal cord injury at least hourly for indications of neurogenic shock. And this is happening the first 24 hours. And you have the full description of the symptoms you are expected to monitor: the temperature, symptomatic bradycardia, hypotension with systolic blood pressure less than 90. Similar to interventions for any type of shock, neurogenic shock is treated symptomatically by providing fluids to the circulatory blood volume, adding vasopressor RV therapy, and providing supportive care to stabilize the patient. In addition, respiratory compromise, pulse ox, less than 95%, or symptoms of aspiration, stridor, garbled speech, or inability to clear airway may be treated with intubation or bronchial endoscopy. Assessment. Airway, breather circulation. Monitor the patient who has high-level SCI injury for the additional risk of autonomic dysreflexia. It's a neurological emergency and must be promptly treated to prevent a hypertensive stroke. I'm going to repeat. Autonomic dysreflexia is a neurologic emergency and must be promptly treated to prevent a hypertensive stroke. So you don't want the patient under your care to have this complication, Probably this is going to be a fatal event, and I hope you can sleep that night. Critical rescue. If the patient experiences AD, raise the head of the bed immediately to help reduce the blood pressure as the first action. So you need to put and sit the patient immediately. That's good to know. Maximum NCLEX alert. Question. A client who is experiencing a recent T1 spinal cord injury, which is above T6 and is below C8, appears flushed and diaphoretic in the face and neck, and is reporting seeing spots, which are all of those are symptoms of autonomic dysreflexia. Which action would the nurse take first? Raise the head of the client's bed. Factor number 3, preventing secondary spinal cord injury interventions during the immediate care of the patient. With a suspected or confirmed cervical spine, a hard cervical collar is used, placed to stabilize the spine until a specific order indicates that it can be removed. If you see a patient having a spinal cord injury, do not ever move the patient, especially the cervical area. Please let the EMT or the doctor to give you instructions about that. So that's here we have the best practice for patient safety and quality care, emergency care. Place patient in a seated position. This is a review of the autonomic dysreflexia. Check for urinary retention, urinary catheter tubing, determine if a urinary tract infection or bladder calculus stones are contributing to genitourinary irritation. Check the patient for fecal impaction or other colorectal irritation. Monitor blood pressure. Give medication in order to treat the blood pressure. If the patient has a fractured vertebra, the primary concern of the healthcare team is to reduce and immobilize the fracture to prevent further damage to the spinal cord from bone fragments. Non-surgical techniques include external fixation or orthotic devices, but surgery is often needed to better stabilize the spine and prevent further damage. Spinal fusion or managed cervical injuries are the type of procedures. The spinal fusion is when they put the two parts together and they put like a piece of metal, right, to put together these two pieces. After surgical spinal fusion, assess the patient neurologic status, vital signs, and this is nursing is all about this: assessment, all about neurological status, vital signs, at least every hour for the first 4 to 6 hours. And then if the patient is stable, every 4 hours. We're talking about post-surgery common sense assessment. Assess for complications of surgery, including worsening of motor or sensory function at or above the site of surgery. I will check for reflexes, pulses, okay? Your neurovascular assessment. The patient may be placed in fixed skeletal traction to maintain vertebral alignment, facilitate bone healing, and prevent further injury, often after surgical stabilization. The most commonly used device for immobilization of the cervical spine is the Halo fixator device, or called Halo crown, which is worn for 6 to 12 weeks. We are going to see the picture later. Nursing safety: never move or turn the patient, as I told you, by holding or pulling on the Halo device. Do not adjust the screws holding it in place. Check the patient's skin frequently to ensure that the jacket is not causing pressure. Who's gonna touch the screws? Por Dios. Pressure is avoided if one finger can be inserted easily between the jacket and the patient's skin. Like when we use other type of devices, We always try to put the finger below to see if there is enough space, right? Monitor the patient's neurologic status. Check strength. Do not use sharp objects, coat hangers, knitting needles, really, to relieve itching under the vest. Skin damage and infection will slow recover. More serious but less common complications includes, and that's good to know, okay? This part of the do not put sharp object is good to know. More serious but less common complications include osteomyelitis, cranial bone infection, subdural abscesses, and instability. Monitor infection, fever, purulent drainage from the pin sites, and report. Assess. Okay? For thoracic and lumbar functions, if you know your assessment and you conduct your neurological vascular assessment, you check your fever, your lung sounds, your cardiac, pulse ox, capillary refill, okay, you're safe. You are safe. If you do that, you are safe. For thoracic and lumbar functions, metal or steels, the Harrington rods are used to keep the bone ends in alignment after fraction reduction. Because SCI is a physical trauma, the patient is started on a proton pump inhibitor such as pantoprazole to help prevent the development of stress ulcers, which is in the abdominal area, right? An anticoagulant may be given as part of UPT, venous thrombotic event prevention protocol. Bulk forming laxatives or stool softeners are given to prevent constipation. So that's good to know. If they might ask you, the patient is having an SCI, what medications is the nurse expecting the provider to order, right? So you know if the patient is going to go surgery or the patient is recently admitted, and they are going through this physical trauma, they are going to probably order anticoagulants, they are going to probably order analgesics, this pantoprazole, and this and that. Those are logical medications that you need to be aware, you need to be familiarized with those, okay? So calcium and biphosphonates may prevent the osteoporosis that result from lack of weight bearing or resistant activity. Also, you need to be familiarized with those medications. Another question, a nurse is caring for a client with a spinal cord injury, being treated with a halo fixator with vest. Which action by the nurse is most important? Assess the pin sites daily. You need to assess for infections, redness, besides taking temperature. Provide straws for ease of drinking. This question was easy. Factor number 4, managing decreased mobility interventions. Patients with SCI are especially at risk for pressure injuries due to altered sensory perception of pressure. Areas on skin below the level of injury. They are also in risk for venous thromboembolism, contractures, orthostatic hypotension because they have been in bed for a long time, especially in patients with high SCI because motor functions are going to be impaired, and fractures related to osteoporosis due to impaired mobility. Reposition patients every 1 to 2 hours, and if your CNA doesn't want to help you doing so, you look for another nurse and you do your job. You reposition these patients every 1 to 2 hours. Assess the condition of the patient's skin, especially over pressure points. With each turn and repositioning, check the skin, provide skin care based on the provider's protocol. Paraplegic patients usually perform frequent wheelchair push-ups to relieve skin pressure. I want to say something. When you reposition the patient, always use good body mechanics. Always. You don't want to get hurt by repositioning the patient, right? Use your pillows, your skin protectors for the patient, and you use your good body mechanics. I'm sure the hospital or the institution you're going to work for is going to train you on body mechanics. Patients with cervical core injuries, especially at high risk for orthostatic hypotension, but anyone who is immobilized may have this problem. And we are talking about the prevention of venous thromboembolism. And we need to use the pneumatic compression stockings to prevent this problem. Okay. Also assess for hypotension, which could result in dizziness and falls. I've seen this a lot. Fall is a hospital-acquired condition. It could cause fractures. And if the patient is coming with a spinal cord injury and a fracture in a hospital, I don't even want to think about this situation. Patients with paraplegia are usually able to transfer from bed to chair or wheelchair with minimal or no assistance unless balance is a problem. Techniques to improve balance are usually taught by occupational or physical therapists. Tetraplegic patients with this, the immobilization of the four extremities, the arms and the legs, may learn how to transfer using a slider, also called a sliding board. So all patients with SCI require bowel and bladder training, including adequate fluids and stool softeners to prevent constipation from immobility and the injury itself. Enemas are going to be given often. Those with upper motor neuron lesions, usually cervical and high thoracic injuries, your T1 to T5, have a spastic bladder and bladder function with an intact spinal reflex for elimination. However, voiding patterns may be uncontrollable and require long-term indwelling and external catheters, leading to frequent urinary tract infection, which is a hospital-acquired infection and is a no-no. Nurses, do your job, protect your license. Care coordination and transition management, the rehabilitation phase is usually after an acute SCI and begins in the acute or critical care unit when patients are hemodynamically stable. They are usually transferred from the acute care setting to rehabilitation setting, where they learn more about self-care, mobility skills, and bladder and bowel training. Living with a spinal cord injury in the community, a full-time caregiver, a good one, try to look for somebody good with compassion. Or personal assistant is sometimes required when the patient with tetraplegia returns home from rehabilitation. So you have some articles about evidence-based practice and what patient needs to know about aging with a spinal cord injury. Important points about, for example, vaccination. You need to prevent respiratory complications. For women, they need to have a Papa Nicolau, a pap smear, and mammograms, because limitation in movement may make breast self-awareness difficult. Measures to prevent osteoporosis, the proper intake of vitamin D and vitamin C to avoid caffeine, practice meticulous skin care to prevent constipations, to drink adequate fluids, high fiber diet, to add stool softener, bowel stimulant, and establishing a regular time for bowel elimination. Modify activities if joint pain occurs. Use a powered rather than a manual wheelchair as the primary healthcare provider about treatment options, and I'm sure they are going to guide you to get all these resources depending on the insurance. And basically evaluation, assessment. And we're done with this topic. Please make sure to review the video at the beginning. It's an excellent review. Make sure you master your neurogenic shock, your spinal shock. Make sure you understand your autonomic dysreflexia. These are points in very important concepts for NCLEX. And let me tell you something. If you don't see these questions in this unit exam 1, you are going to see them in the final. So I am reviewing killing many birds in one shot, reviewing for the exam 1, reviewing for the final, giving you information for the NCLEX, okay? Okay, guys, thank you so much. Stay tuned when we come back. Low back pain, we are going to review this, and there's one more topic in this chapter, and we are almost done. Thank you.